As I explained in this current video, we will be having a brief overview of oxygen utilization in our body, and we'll be going through the most important aspects related to the same. We all know that very important molecules that we need for normal functioning and survival are oxygen and glucose. So without these two key molecules, we would not be surviving. Glucose is obviously a main fuel based on which all the body functions happen. The glucose breakdown in the aerobic metabolism pathway starts with glycolysis, where you have a pyruvate generated, and this pyruvate is broken down to acetyl-CoA as it enters the mitochondrion. It enters the Krebs cycle, where the acetyl-CoA is converted to oxaloacetate. In the process, it releases NADH, and which enters the oxidative phosphorylation. The oxidative phosphorylation, or the electron transport chain, is in the mitochondria, and it's the main mechanism by which the body releases ATP, which is the energy molecule, or the currency for energy, so to speak. For this aerobic pathway to function, that is to utilize the glucose appropriately to release the 30 to 34 ATP per molecule of glucose, oxygen is a key. So without oxygen, we will not be going through the aerobic pathway. We will be entering the anaerobic pathway, and unfortunately the anaerobic pathway is not efficient. It only leads to 2 ATP production per glucose molecule, which is not viable. So this summarizes what we discussed. I know it's a bit intense, but I'll keep it brief. We don't need to go into the full details of the cycles. So when we have aerobic respiration, it starts with the glucose, which undergoes glycolysis, and we have the 2-pyruvate produced. The pyruvate under aerobic conditions goes into the mitochondrion and converts to acetyl-CoA by decarboxylation. Acetyl-CoA is the starting path of Krebs cycle, or citric acid cycle, or tricarboxylic acid cycle. So we have the citric acid cycle, and as I said, NAD and converts to NADH, and FAD converts to FADH, and we have 6H plus produced as well. So all this will go into the electron transfer chain pathway, which is the main pathway through which the ATP is produced. In case you don't have oxygen, it goes into the anaerobic pathway, where the pyruvate gets broken down to lactic acid and ethanol by fermentation process. So acetyl-CoA is not formed, the Krebs cycle is not entered, and only 2 ATP molecules are produced as part of this process. So it's a very inefficient system if you have anaerobic metabolism. And the same happens in tissues which don't have the oxygen perfusion. So you have anaerobic conditions there, so they are not able to use aerobic glucose, aerobic fuel mechanisms. You do have lactic acid increasing in these situations, and that's why lactate is used as a marker of such conditions. The same happens with the baby born in a birth asphyxiated condition. The same happens in a baby with shock, where there is poor perfusion in the periphery. So this is a simple representation of the oxidative phosphorylation, the electron transport chain. So you have coenzyme Q, cytochrome C, and various other factors. Mainly the electron transfer happens along these different stages, and it ends up giving us 30 to 34 ATP. Because of the leakage and because of the energy used in the process, even though we say up to 38 can be produced, in practice, in reality, we only get 30 to 34 ATPs which are produced. The reason I started explaining this is for you to know why we need oxygen, because that's the key as to why we need to target oxygen, why we need to maintain it at an appropriate level, and why the baby suffers from lack of oxygen. So for the adequate fuel production in the body, we need oxygen along with glucose. Now, coming on to the point of oxygen uptake. Oxygen in the alveolar air gets transferred across the alveolar capillary interface. So this is the starting point, because our body excretes carbon dioxide and we consume oxygen. The oxygen exchange happens in the healthy lungs. So you might have a problem in the lungs which affect oxygen exchange. So enough oxygen doesn't enter the bloodstream, and that's how lung disease affects oxygen. Majority of the oxygen is bound to hemoglobin, almost 98+%, and a small proportion is dissolved in the plasma. So we should remember that it is this small percentage that we are actually measuring when we do the partial pressure of oxygen in the blood gas. The oxygen is then circulated to the rest of the body by the blood. So blood is just the vehicle to carry the different substrates that we need for the adequate functioning. So oxygen, glucose, etc. are carried to the tissue. Carbon dioxide and other waste products are taken out from the tissues and brought to the kidneys or the lungs to be excreted appropriately. So the blood is a vehicle to carry essential things to the different parts of the body. Oxygen is then released at the tissue level capillaries, and this produces essential oxygen for the tissue function and metabolism. So if you understand the whole cycle of how the body works, so we get oxygen into the blood from the lungs. The hemoglobin is a main carrier, so the blood cycles to the periphery and the tissue takes up the oxygen that it needs, and then the oxygen enters the cells to help with the aerobic metabolism process to produce the energy to drive the local metabolism. So this is the same whether you're talking of the kidneys, you're talking of the muscles, you're talking of the brain, the heart. So any part of the body, aerobic metabolism is key. We mentioned that hemoglobin is a key carrier of oxygen, and this is the structure of hemoglobin. We have the 4 globin chains, which are the protein components. The globins can be 2 alpha chains as in both fetal and adult hemoglobin, and the 2 beta chains in hemoglobin A. If you have 2 gamma chains, it becomes hemoglobin fetal hemoglobin, and 2 delta chains makes hemoglobin A2. So different abnormalities of hemoglobin like sickle cell and so on alter the chemical composition of the globin chains, and in thalassemias we have less of the particular chains according to whether it is alpha thalassemia or beta thalassemia. So this is about hemoglobin. The main oxygen carrying component is the iron containing heme in the hemoglobin, and there are structural changes which happen in the hemoglobin which allow appropriate release of oxygen to the tissues and uptake depending on what is happening. So coming on to the uptake and release, we have the very important concept of the oxyhemoglobin dissociation curve. All of us are familiar with this. Just a quick overview of what it is so we can understand better. So we have the partial pressure of oxygen in millimeter mercury on the x-axis. We have the oxygen saturation of the hemoglobin in percentage on the y-axis. And obviously it's a sinusoidal or S-shaped curve. And the normal is in dark line, that's adult hemoglobin based. We have a shift to left, which is often the situation in the newborn period because of the high hemoglobin F that we have, and even in that you may have further shift to left or further shift to right depending on the factors we will discuss next. A shift to right may happen as well in certain situations as we will discuss. So when we say shift to left or shift to right, what we basically mean is that the shift to left will make the hemoglobin bind the oxygen more strongly. So for a given available hemoglobin oxygen level, the hemoglobin is more saturated. So suppose we have a hemoglobin, a partial pressure of oxygen of 60 with the shift to right, your saturation will be around 80, while with the shift to left, your saturation will go as high as 90. So this indicates that when you have a transfusion or multiple transfusions in a newborn, the fetal hemoglobin is partly replaced by adult hemoglobin, which shifts it to the right. So what you have as a 95% saturation on day 1 may actually be 90% after some transfusions at the same PaO2 level. So that is one of the things we should remember, that focus on saturation range is important, but the exact number within that range is okay, and we can start accepting slightly lower saturations as a transfusions, number of transfusions that the baby gets is more, and we will discuss that later as well. So shift to left is usually seen in newborns. As we said, there is more avid binding and relatively tighter release. This can happen with increased HbF, a lower level of 2,3 to DPG, and we can have hypothermia, alkalosis, hypocarbia, all shifting to the left. So even in older kids and adults, this can happen if these changes happen. And the level of 2,3 DPG, obviously, when you give transfused blood, the age of the blood has an importance in terms of the 2,3 DPG content, depending on what stabilizers we use for the bloods as well. So a fresh blood usually has more 2,3-DPG, and as the age of the blood increases, 2,3-DPG keeps dropping, and that's one of the reasons we have the additional components added to the packed cells to maintain the 2,3-DPG function. And we also have a shelf life for the blood for mainly the same reason. After some time, it doesn't release the oxygen in the tissues well. So if the baby is really sick, go for a fresh air bag as far as you can. And shift to right where there is easier release to the tissue happens with acidosis, hypercarbia, hyperthermia, reduced proportion of fetal hemoglobin, or increased 2,3-DPG. I hope this concept is clear. It's very important to understand this so you know what we are talking of when we talk of PaO2 and saturation. Coming to the important concept of tissue oxygenation. So now we spoke of oxygen uptake into the blood and carriage in the hemoglobin. Now tissue oxygenation is actual delivery of the oxygen to the tissue. So it depends on oxygen content in the blood. Oxygen content in the blood depends on how much hemoglobin is there, as well as how effective the oxygenation is in the lungs. So if a child is anemic, for example, or if a baby is anemic, they have a lower content of hemoglobin, and their ability to carry oxygen is limited. To some extent, this is offset by increased cardiac output, as we will discuss, by increasing the heart rate. So anemia causes tachycardia for the same reason. Efficacy of oxygenation in the lungs, obviously, in a normal situation, it doesn't matter. But in the case of lung disease like a pneumonia or respiratory distress syndrome, where the oxygenation is not happening normally, this plays an important role, because if the oxygen is not getting into the blood in the first place, the tissues are not going to get enough oxygen. And that's where our importance of FiO2 that we breathe in, the need for pressure support, the need for surfactant, all these come in. The next important part that affects tissue oxygenation is the cardiac output and the tissue perfusion. So cardiac output is a component where stroke volume is times the heart rate gives you the cardiac output. So cardiac output is stroke volume times heart rate, and the stroke volume is contributed by the preload, which is amount of blood returning back to the heart. So that indicates how much filling of the atrium is there. The degree of stretching of the atrium, the Frank-Starling law applies, and that affects the myocardial contractility. So if the heart is not filled adequately, the stretching of the muscle doesn't happen, the pump may not work as effectively. That's where you may need inotropic. And when we talk of afterload, that is the resistance to the heart pumping in the rest of the systemic circulation. So if there is a peripheral vasoconstriction, your afterload is high. And when we give inotropes, for example, like dopamine or dobutamine or any other medication, we have to think of how they impact on all these components. So a vasodilator, for example, reduces the afterload. It makes it easier for the heart to pump. Most of these medications increase the heart rate, and so the heart rate goes up, the cardiac output may increase. However, if the heart rate goes up too much, your preload may be reduced, and the filling of the atria reduces, so the contractility is not going to be as effective. So excessive increase in heart rate is not a good thing in these situations. And again, if you use a strong medication like dopamine, which causes peripheral vasoconstriction, to increase the blood pressure numbers, the numbers go up, but actually if the pump is already failing, the heart has to pump even harder, so it doesn't necessarily improve the outcome for the patient. That's why we should be very careful about the choice of the medication we are using to support the blood pressure. If you don't have enough filling, the preload is an issue, and we may need to give more volume. If myocardial contractility is an issue, you give inotropic agents and possibly something to lower the afterload, like a mild vasodilator, like milrinone is a good choice in these situations. And if myocardial contractility is good, but the systemic vessels are dilated, for example, you may give dopamine to increase the peripheral vascular resistance. That will improve the blood pressure. So oxygen content is basically the amount of oxygen that is dissolved in the blood and the hemoglobin. 1 gram of fully saturated hemoglobin carries 1.3 ml of oxygen. and a small amount dissolves in the plasma. So this is a very small percentage, 0.0031 ml per deciliter of blood. So for all practical reasons, this can be ignored, except that this is the measure that we use for the PaO2 on the blood gases. This correlates usually with the extent of saturation. However, we should remember that saturation reflects the saturation of whatever hemoglobin is there in the child. So if you have only 10 grams of hemoglobin, your actual content of oxygen will be low, but the saturation may still be normal. So you should remember that anemia is one factor we should think of in terms of oxygen content of the blood. So normal oxygen content is approximately 20 ml of oxygen per deciliter, depending on the site from which the blood is sampled. Obviously, arterial blood has more oxygen content, and it drops to the capillaries, and then in the venous blood, whatever is extracted is subtracted from this total. So as I said, in the steady state, 4 to 5 ml per deciliter is utilized in the tissue. So the venous blood will have about 5 ml less, so 15 ml in the venous blood. We have a substantial reserve if the blood flow is reduced or demand for oxygen increases. So you can say 5 times or 4 times the reserve in normal conditions. After we have the oxygen content, we look at oxygen delivery. This is the amount of oxygen transported from the lungs to the microcirculation. Oxygen delivery depends on the cardiac output and the oxygen content of the blood. And as the cardiac output in the newborn is about 250 ml per kilo per minute, and the oxygen content is 20 ml per deciliter, that means 20 ml per deciliter and 250 is 2.5 times that. It's 50 ml per minute is the oxygen delivery in normal conditions. After you get to the oxygen delivery, we talk of the oxygen consumption, which is actually the amount consumed in the peripheral tissue. So once the blood reaches from the arterioles to the capillary circulation, oxygen goes into the tissue as per the needs of the tissue, and the rest of it will stay in the blood, which comes back to the venous circulation. So the difference between the arterial and the venous oxygen will give you the oxygen consumption, and that is multiplied by the cardiac output. And the resting oxygen consumption, as we discussed earlier, is 4.5 to 7 ml per kg per minute. And suppose you are studying for the exam, for example, or you're preparing for a presentation, your brain is working more, so your oxygen consumption in the brain is more. If you're sleeping or you're just watching a video to relax, you may be finding a lower consumption in the brain. So brain is actually a quite avid user of both glucose and oxygen. That's why if you are sitting through a whole day in the clinic, you feel tired even though you have not done any physical activity. When we talk of oxygen measurement, we'll be talking a little bit about near infrared spectroscopy, and this is the tool which actually measures or monitors the oxygen consumption in the tissue. So you actually get a tissue level picture. So to summarize this video, oxygen is essential for normal functioning, as we saw. Lack of oxygen leads to anaerobic metabolism. Lactic acidosis sets in, and we have complications like hypotension, shock, and the brain is affected as well. If there is low oxygen to the brain, you may have fits and other complications. So an altered sensorium which happens in hypotension or shock mainly happens from reduced glucose and oxygen delivery to the brain. The fetus is in a hypoxic state, but it has adapted. So there is a high cardiac output, a high fetal hemoglobin, high hemoglobin as well. And the same adaptation can happen in cyanotic heart disease to an extent where even after birth, the baby's metabolic processes have stayed in the relatively hypoxic state, as the baby has never seen a high PaO2 content. Same way, the PPH in babies can manage to an extent as long as there is no acidosis building up. Our target oxygen should be a level where we don't flog the lungs. So we should preserve as much as possible, support the physiology as long as the body is compensating. Adequate oxygenation needs careful monitoring and titration of the oxygen delivery, which will be one of the topics that we will discuss next. So the objectives of this video is to give you an overview of oxygen toxicity and the antioxidant system, as well as an outline of how oxygen impacts on our various diseases, including bronchopulmonary dysplasia and retinopathy of prematurity. So just a few definitions to start with. So we have hypoxemia, where there is reduced oxygen carriage in the blood. As we discussed in the first video on oxygen, this can be related to pulmonary factors which affect gas exchange or right to left shunting. The next aspect is hypoxia, where there is reduced tissue oxygen. So this can be related to reduced oxygen in the blood, which is hypoxemia, or it can be due to reduced cardiac output, severe anemia, or a combination. Hyperoxemia mainly results from excess oxygen administration relative to patient needs. So there is more oxygen in the lungs, and when the lungs are relatively normal, more oxygen gets into the bloodstream. We have a higher partial pressure of oxygen in the blood. Hyperoxia is where there is excess oxygen at tissue level. So both hypoxia and hyperoxia are harmful. Hypoxia can be harmful in terms of switching to anaerobic metabolism, which is quite an energy inefficient way. So we have energy failure. So details of this are available in the first video on oxygen as well. Acid accumulation in the tissues results from anaerobic metabolism, and so metabolic acidosis happens. When the acidosis worsens, it affects the myocardial functioning, and it can lead to further hypotension and shock. Pulmonary vasoconstriction is also a result of hypoxia, and this leads to further hypoxia by the resulting right to left shunt. So this is another cycle which worsens the hypoxia. Due to the hypoxic injury, we have damage to the membranes. Apoptosis might happen, and this might increase mortality. It also has effect on different organs, especially the brain. And the neurologic injury can be associated with the adverse long-term neurodevelopmental outcome. If the hyperoxia is prolonged or severe, it can be harmful in any age group. So hyperoxia is seen much often in the neonatal unit. We are not worried much about it in the full-term babies, but we should be, because oxygen can be harmful, and oxygen should be treated like a drug. As we prescribe other drugs, we should be clearly monitoring. The advantage of oxygen monitoring is that the nurses can be trained. They are by the bedside, they can titrate the oxygen, and of course, as we will discuss in one of our future videos, we have a closed loop oxygen system as well, which can help regulate the oxygen delivery to the saturation which is measured. So preterm neonates are at a much higher risk from the hyperoxia effect. They are at risk of retinopathy of prematurity. We will discuss in detail about how it works in one of the next slides. There is increased risk of bronchopulmonary dysplasia from exposure to oxygen-free radicals and the related damage. One of the underlying factors is obviously the immaturity of the retina in terms of ROP, the immaturity of the lung, and a higher need for respiratory support and oxygen in terms of the lung disease. And this also is related to the fact that the preterm infants lack a fully functioning antioxidant defense system, including glutathione peroxidase and superoxide dismutase, and they are more exposed to other aspects which can worsen this defense. A quick summary of what oxygen toxicity is caused by. So we have the reactive oxygen species, which we will keep referring as reactive oxygen species, or ROAs in short, in the further slides. So we have many examples of that. Obviously, I have mentioned a few here. Superoxide anion, all of us are familiar. Hydrogen peroxide, lipid peroxide, peroxyl radicals, electron delocalized phenoxyl radical, nitric oxide. It is a free, it's a free radical as well. And we have the hydroxyl radical, which is quite damaging to the tissues. So the hydroxyl radical, represented as OH dot, is one of the strongest oxidants in nature, and it may damage the tissues. There is no specific scavenger for this radical, and once released, it reacts with the lipoproteins, the cell membranes, the lipids, DNA, amino acids, causing structural and functional damage. So this is a reflection of how the free radical injury causes tissue damage. Almost all the reactive oxygen species cause damage by any of these mechanisms. The main source of the reactive oxygen species are as part of the NADPH oxidase reactions. In the first video on oxygen, we discussed the electron transport chain in the mitochondria, and the NADPH oxidase reactions happens in those regions. So it's also part of the reaction in the phagocytes after activation, when they're exposed to microbes, microbial products, or inflammatory mediators. So phagocytes are obviously brought into the tissues wherever there is inflammation, and so any inflammatory mediation can cause increased reactive oxygen species. So this point is very important to remember when we talk of maternal problems like chorioamnionitis and the effect of that on lung disease and so on in the baby. So the fetal outcome, both in terms of the brain outcome as well as the lung outcome, depends a lot on presence of inflammatory mediators at birth, and that is partly because of this increased reactive oxygen species. Then we have the reactive oxygen species as part of the mitochondrial metabolism. We have hypoxia and reoxygenation. This is typically seen in birth asphyxial injury. So where we have secondary or reperfusion injury, the cooling is intended to reduce this type of injury. So here we have a hypoxanthine xanthine oxidase reaction. Hyperoxia, of course, leads to reactive oxygen species, and paradoxically hypoxia also leads to increased reactive oxygen species. So the nature of the products are different in each, but obviously the damage that happens, as we discussed earlier, at these cellular levels can happen both with hypoxia and hyperoxia, and the reoxygenation or reperfusion is important as well. So in terms of oxidative stress, we have an excess of reactive oxygen species in relation to the detoxification capacity, and that leads to oxidative stress. The detoxification capacity is nothing but the antioxidant system. So imbalance between oxidants and antioxidants leads to a potential damage of the tissues. Mild oxidative stress is seen quite commonly in our day-to-day life, and the cell and the antioxidant mechanisms we have in our body can protect us from such stress. However, severe oxidative stress is generally followed by cell injury, and any type of cell death like apoptosis, necrosis, autophagy, mitophagy, anything can be a relation to the severe oxidative stress. And remember that these can lead to hemolysis, it can increase the risk of NEC, it can increase the risk of brain damage. So any type of brain injury can happen from increased reactive oxygen species. And coming on to the defense mechanism itself in a little bit of detail, an antioxidant is a molecule capable of inhibiting the oxidation of other molecules. The antioxidant defense system can be primary or secondary. The antioxidants can neutralize the free radicals at 3 levels. We can call it prevention, interception, and repair. Prevention, an example is superoxide dismutase, which catalyzes the dismutation of superoxide to hydrogen peroxide. Catalase is an example as well, and this breaks down the hydrogen peroxide to water. In terms of interception, it's mainly the scavenging. So the scavenging of free radicals or peroxyl radicals in the tissue, and the molecules involved here include glutathione, the flavonoids, carotenoids, which is related to vitamin A, and vitamin C and E. Repair at the tissue repair level, like the ligase enzyme. We can also look at the primary, secondary, and tertiary antioxidant defense mechanisms. So the primary defense is mainly intended to look out for and protect the body from oxidant damage. So examples are the glutathione, uric acid, vitamin A, C, and E, and bilirubin in newborn babies. So we all know that vitamin A has been shown to have an impact in reducing BPD, and part of it is related to its role in maintaining the epithelial surface, but also it's due to its antioxidant effect. Vitamin C has been tried, and a high level of vitamin C can itself create oxidative stress, so we should be careful not to overdose it. Vitamin E has been tried to reduce problems related to retinopathy of prematurity with some success. However, there is an increased risk of sepsis in very small babies following such stress, and so we should be careful. Even though bilirubin is an antioxidant, very high levels of bilirubin obviously can cause brain injury, so it should not be advocated as a treatment. And in the extreme preterm babies, there has been increased mortality where you aggressively manage bilirubin like prophylactic phototherapy, so we should exercise caution in management of bilirubin because of its role as an antioxidant. Remember that the reactive oxygen species are part of the defense against infections as well through the phagocytes, and that's why too much of inhibition is also to be monitored carefully. So we also have the antioxidant scavenging systems like the peroxidases. In terms of secondary defense, these usually act after damage to the tissues, and these include the lipolytic enzymes, phospholipase, the proteolytic enzymes, and the DNA repair systems. So lastly, we will look at the impact of oxygen toxicity. So we have looked at the important role in tissue damage and how it can lead to different forms of cell death. So they also have an important role following on with this in the development of retinopathy of prematurity, chronic lung disease, necrotizing enterocolitis, renal failure, hemolytic anemia, septic shock, and brain damage, especially in the setting of pre-perfusion injury in perinatal asphyxia. The most important impact when we consider the reactive oxygen species injury is on chronic lung disease of prematurity and retinopathy of prematurity. So this is an illustration of a pathway where the chronic lung disease happens, and we have all the reactive oxygen species that we spoke of. Of course, it can affect the genetic level as well. DNA damage, altered gene expression may happen. So maternal exposure can lead to growth restriction, intrauterine stress, and even death. We have cytochrome C response in the mitochondria. Various enzymes are affected, and it has impact on the phagocyte. It has effect on apoptosis and cell death. The reactive oxygen species leads to inflammation in the lungs. There is disruption of the alveolar capillary membrane. There is microvascular endothelial injury. Inflammation, edema, fibrosis happen. The alveolar flooding continues to occur. Relative surfactant inactivation is noted as well. And it has a secondary effect on the phosphodiesterase enzyme role in the metabolism of cyclic GMP to GMP. There is pulmonary vasoconstriction, and this also contributes to pulmonary hypertension, which is a part of bronchopulmonary dysplasia. So all these impacts are seen acutely where you have greater difficulty ventilating such babies who have a significant inflammatory response. So the start of ventilation in the labor room is very important not to cause hyperoxia. Even the response of nitric oxide depends on the setting. So the enzymes are switched on or off in the presence of hyperoxia. So pulmonary vasoconstriction and a poorer response to nitric oxide may cause pulmonary hypertension as well. In terms of ROP and oxygen, so we have the role of vascular endothelial growth factor. And we have the normal retinal vascular development, which is stimulated by the VEGF, which is usually seen as to produce new vessels as the vessels progress down the retina. And in the first phase of ROP, we have exposure to relative hyperoxia after birth, and this interrupts the gradient of physiologic hypoxia in the mature retina. This leads to downregulation of the VEGF. So the red marking the VEGF is absent here. This is associated with vasoobliteration and cessation of vessel growth, which is seen as a ridge in the early stages of retinopathy of prematurity. As the metabolic demand of the developing retina increases, the non-perfused portion of the retina becomes hypoxic. So the blood vessels are not available, so that area becomes hypoxic, and there is overproduction of VEGF as a result. So this is a cycle of hyperoxia and hypoxia, and the VEGF production results in neovascularization, and this produces the advanced stages of retinopathy of prematurity. When these vessels rupture is when we get retinal detachment. So neovascularization occurs in response to overproduction of VEGF, and if VEGF production persists, the ROP will progress. So you get plus disease, you get the dilated vessels which are seen, and if the VEGF levels decrease, then regression of ROP can happen. And this is the basis for the treatment with anti-VEGF factors that we use now, the Eylea or the bevacizumab and other products that are used injection into the vitreous to inhibit. So we have different factors. We have the free radicals, but however we have the fluctuation of hyperoxia, hypoxia, and in a premature baby, the switch from hemoglobin F to hemoglobin A that is initiated by the transfusions also plays a role. So to summarize and to end this video, we can say that reactive oxygen species plays a very important role in neonatal morbidity and mortality. The focus is on oxygen toxicity is important right from the labor room onwards, and we should advance measures to minimize the oxidative stress. We should support our antioxidant defense by maintaining adequate nutrition, including focus on adequate amounts of vitamin A, C, and D. Caution should be exercised to avoid overdosing. Vitamin A, as we know, has a role in BPD, but it's involving 3 intramuscular injections weekly in the tiny babies, and so the uptake in the society, in the community, is not very high. We should minimize exposure to high levels of oxygen as well as significant fluctuations right from the labor room to the NICU stay.